hazard of spine surgery. Cliff talked about this earlier in terms of disclosures. Part of my disclosures, I work in a fee-for-service healthcare system. And the more surgery I do, the more I get paid. And that's a pretty simple, I'm the busiest surgeon, and I get paid the most at UCSF. It's as simple as that. And that's a real conflict in terms of my discussions with the patients. So if we think about appropriate care, appropriate care is defined as care where the expected benefits exceed the expected risks. And defining and knowing what the expected benefits or risks are important. So really looking at our outcomes critically and also understanding our risks. And we've done a lot of work at UCSF and actually publishing our surgical complications and recognizing a lot of what we're doing is high-risk undertakings. And that ratio of risk to benefit can be challenging to quantify. And the reason is that they're different units, right? Is a death or a neurologic deficit, that doesn't get measured in the same unit as an improvement of ODI score or as an improvement of SF-12 score. So how do we really measure that ratio? And that's where really patients need to be engaged in the process of informed decision making, because we don't have metrics or units that are directly comparable. I think ultimately, and a different talk that I'm not going to give now, but that was the alternative talk for this, is predictive modeling, and really being able to risk stratify patients appropriately and specifically, and trying to continue to develop, as we have done, some tools for both estimating risk, modifying risk, and estimating expected outcomes for individual patients. So what I'm going to focus on now is the notion of our interaction with the patients. And what I find the most difficult interaction of all is talking about, well, what are our alternatives, and empowering